Tirth, let me try, sir, for a minute, okay?
Okay, okay. It is
Cannot
live.
see,
It
sir.
is live on YouTube.
All right.
Hello, Asha Jain ma'am.
Yes, yes.
Shall we start or we have to wait for 1 more minute?
Just one more minute because there is some problem with sir's computer. He's unable to log in. So I've mailed him the
Okay,
link again.
no problem.
Just a second.
Yes.
Okay, so he has joined. So now you can go live.
Okay, okay. Very good evening, respected faculties and delegates present over here. On the behalf of Corona Remedies, I am Tirth Shah. Welcome you all in this Happy Learning Masterclass webinar series, 193rd edition, in association with Raipur, Bhimavaram, Vijayawada, Visakhapatnam, Rajamundry, Kakinada, Illuru, Chittoor. And the topic of the today's webinar is stillbirth, what gynecologists want to know. I welcome Dr. Asha Jain ma'am and Dr. Sujaya Sri Sangeeta ma'am as a convener of today's webinar. Uh, Dr. Asha Jain ma'am has a 34 years of experience in this field. She is a SMS Hospital Raipur, Chhattisgarh, director of SMS Hospital Raipur. Currently, she is a medical director of CPRS, elected member of CG Medical Council, zonal chair of Foxy Food Drug and MSc Committee Based Zone. Past offices of Dr. Asha Jain is a president Raipur Obscene Gynec Society. She is a VP, IMH Chhattisgarh, president Rotary Club of Raipur North. She has a Foxy Recognized Center for Ultrasound Training and Colposcopy Training. Academically, Dr. Asha Jain has a training in colposcopy from AV School of Colposcopy, Chennai.
Enough, enough.
Studied.
Tirth, I think that's enough.
Okay,
Please
okay, okay, ma'am.
proceed.
Okay. And our next convener is Dr. Sujaya Sri Sangeeta, ma'am. Presently, she is a consultant obs and laparoscopy surgeon at Seshadri Hospital, Palakot. She is a founder secretary of Bhimaram Obs and Gynecology Society and secretary of IMA Palakot. She has achieved awards that is Shan as Ratnam Young Gynecologist
వీడియో
Award
తర్వాత పెడదాం.
and Foxy Dhira Award. Area of interest is laparoscopy and infertility. Academic events, he has participated in organizing secretary of GUSA 2016 and 2018, and some community works like conducting awareness program, Vikasam for Adolescent Girl, and this program has received award from recognition by District Lions Club. So before we move our agenda and before we start our session, let's pray together and let's join our digital prayer as our culture. It is audible?
Yes.
Not
No,
audible.
it is
Not audible.
What? Not audible.
Oh,
You need to share again with sound.
yes, yes. Now it is audible.
Yes, audible.
So now I'm handing over this session to Dr. Asha Jain ma'am. Asha Jain ma'am, over to you. Ma'am, you are muted.
Namaskar. I welcome all of you to this 193rd edition of Happy Learning Masterclass. This is the brainchild of Dr. MC Patel sir, and he has been doing it consistently over the last 3 years. Everybody knows sir, so I will give his formal introduction before his talk, but I would like to say that he is a very approachable, consistent senior and a medical legal expert who's always there for everyone 24/7, 365 days a year. So over to you, sir, for the formal welcome address.
Thank you, Dr. Asha. Am I audible?
Yes, sir.
Am I audible?
Yes, sir. Yes, sir.
Yes. It gives me immense pleasure to welcome you all on 193rd episode of Rajmundry, Vijayawada, and Visakhapatnam. I welcome three guests of honor who has kindly consented to be guest of honor to bless the webinar. Dr. Ramadevi Madam from Kakinada, Dr. Sitaram Rajan Sir from Vizag, and Dr. Sajja Padma Madam from Rajmundry.
Namaste, sir.
Good evening, sir.
Good evening.
And they are always with us to inspire us as far as any of academic activity is concerned. So welcome Ramadevi Madam, Sitaram Rajan Sir, and Sajja Padma Madam. I also welcome Dr. Satyavarthi Madam from Kakinada. She is going to discuss very important topic for today's webinar, that is etiology and management of stillbirth. I also welcome three learned chairpersons who are going to chair that very session. Dr. Aruna Kumari from Rajmundry, Dr. Sesasai Tirupati sir from Chittur. He is busy with some exam, etc., but he will join whenever he is free. So we welcome him also. I also welcome Dr. Saraswati Madam from Kakinada. And in second topic, I am going to discuss IUFD aftermath and beyond. And to chair that very important session, three chairpersons. I welcome Dr. Nirmala Devi Madam from Illuru, Narsingha Rao Sir from Vizag, and Dr. Sujata Madam from Vijayawada. And very interesting panel, Dr. Padmaja Madam from Vijayawada is going to conduct, and that is prevention of stillbirth. And all learned panelists, Dr. T. Padmaja from Rajmundry, Dr. Bibi Salini Madam from Chittur, Dr. Uma Madam from Vijayawada, Dr. Usha Prasad Madam Dr. K. Gayatri Madam from Vijayawada, Dr. C.V. Avani Madam from Vijayawada, Dr. Sairam Madam from Sairam Madam and Dr. Rao Bahadur from Vijayawada. I also welcome two learned personality, Dr. Neelam Agarwal Madam, she is President of Stillbirth Society of India, and Dr. Tamkin Khan Madam, she is Secretary of Stillbirth Society of India. They are going to give their important inputs at the time of panel, and as far as work going on in Stillbirth Society of India, they will give their inputs also. I also welcome Dr. Asha Jain, who is convener for not only for this webinar, but in this series since long. I also welcome Dr. Sujay Sri, she is convener for today's webinar, and in past also she has served as a convener in this series. I also welcome Dr. Rekha Rajendra Kumar, President of Bengaluru Society. She is coordinator in this series since long. And I welcome all the President and Secretary of joining society, that is Chittur, Iluru, Kakinada, Nellore, Rajmundry, Vijayawada, and Visakhapatnam. In COVID-19, when I started this series with 4 friends, at that time, aim was to meet our Foxian friends to discuss focus topic. But now this series is continued, and I am happy to announce, just I mentioned prior also, it is 193rd episode. And every time we discuss very focused topic and meet our Foxian friends on virtual ground. So without wasting much of your time, welcoming you all the delegates, all the guests, all the President and Secretary to this webinar. Thank you very much.
Thank you, sir. Thank you. Now, I would like to, Tirthji, may I have the CVs, please?
Yes, ma'am, sure.
I would like to welcome Dr. Sita Ramaraju, sir,
Good
as
evening,
our
all.
first guest of honor. Next, he was the president of Obstetric Gynec Society of Vizag 2023. He has presented papers in state, national, and international conferences. He has worked as vice president and secretary in Gynec Society of Visakhapatnam, received Foxy Achievers Award 2023. He was selected for WHO Fellowship in 1998. He's worked in USA for 6 weeks and Canada for 6 weeks in IVF and laparoscopy. He has received the Icon Award Times of India from Honorable Shri M. Venkaiah Naidu Garu, former Vice President of India. Welcome, sir. We are really honored to have you here, and we would love to hear words of blessings from you.
Good evening, all, madam. Good evening, madam. I am very happy to be part of.
Namaskar, sir.
I am very happy to be part of Happy Learning Masterclass webinar series under the guidance of Dr. M.C. Patel, Foxy Vice President, and Dr. Asha Jain, past President, Raipur Society, Surya Jaisri, Secretary from Palkon. About Dr. M.C. Patel, Senior Consultant Obstetrician Gynecologist and Medical Legal Counselor, Ahmedabad. His area of interest, tribute to medical legal, phone call away from assistant in medical legal crisis and IVF pregnancy. I think he's going to contesting for the post of Foxy President 2024. We all give great support him and make him success. I used to attend his lecture classes given in various conferences. Today's subject, stillbirth, is very interesting. Stillbirth is a tragic event defined as the death of baby after 20 weeks of pregnancy, but before or during delivery. It can be incredibly difficult and emotional experience for parents and families. For the parents and families, we have to give coping and support. That is very important. Okay, ma'am. Thank you, ma'am.
Thank you so much, sir. Sir, if you would just adjust your camera a little, we could see your face a little better.
Okay, ma'am.
Thank you, sir.
Thank you.
Thank you so much. May I have Rama Devi ma'am's CV, please? So Dr. Rama Devi ma'am is a retired professor of gynae at Rangaraya Medical College, Kakinada. She has served as president of Kakinada Society for 3 consecutive terms. She is currently working as director and senior obstetrician and gynecologist fertility specialist at Sri Divya Hospitals, Kakinada. She is a faculty in national and state conferences, has 27 years of teaching experience, and high-risk obstetrics, infertility, and adolescent gynecology are her fields of interest. Welcome, Rama Devi ma'am.
Thank you,
We are
ma'am.
eager
Thank
to
you
hear
very
your
much.
words of blessings.
Thank you, ma'am. Thank you very much. Am I audible, ma'am? Am I audible, ma'am?
Yes, yes, ma'am. Yes, ma'am.
Okay. Thank you very much, ma'am, for the lovely introduction. And good evening, all dignitaries and all my fellow Foxians. And first of all, I would like to thank Dr. M.C. Patel, sir, and Dr. Sujay Shri, for giving me this golden opportunity of I am present on this web platform as a guest of honor. Thank you very much once again. And in fact, what I feel about this webinar series, Happy Learning Masterclass, is it's absolutely a superb idea that all gynecologists, obstetricians are on the same web platform, learning so many common obstetric complications and the solutions, and also medical legal implications, medical legal issues and all. So that, they can manage. It will help really in the practical management. Am I visible?
Yes, ma'am. You are
Okay.
visible and audible.
Okay, thank you very much. So, and also we can discuss the evidence-based protocols so that we can avoid these litigations or medical legal litigations and all. Because today's particular topic of antepartum stillbirth is absolutely a catastrophic event, most traumatic event psychologically not only to the couple and the family members, but also to it's a shocking news to the attending obstetrician and her team also. That's why we must keep a record of all important antenatal events, and at the same time we must try to get what could be the possible cause of fetal death, what exactly is the possible cause of death, or even what could be the probable cause of fetal death. We must investigate so that we can prevent such occurrence in the future pregnancy. That is absolutely very, very essential. This will help for the psychological counseling of the particular couple, and even that will go a long way in preventing a recurrence of future pregnancies. Because in future pregnancies, very, 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 we have to investigate: is it a fetal cause? Is it a maternal cause? Is it placental, unexplained? Is it preventable or not preventable? All these are very, very important. You must investigate deep, and then we have to follow in a future pregnancy in a very diligent manner. First trimester, second semester screening, and anatomical fetal survey, serial growth studies starting from 28 weeks onwards. Make use of the latest technologies, Doppler studies, so that we can predict the antepartum fetal distress, and we can prevent a stillbirth. This is very, very essential. So I'm sure this today's panelists and today's speakers are going to enlighten us with almost all the aspects of antepartum stillbirth, and also finally we're going to be guided by our sir MC Patel sir regarding the medical legal aspects also. So let's all wait for this deep discussion that's going to enlighten us. Thank you very much for giving me this opportunity once again.
Thank you so much, ma'am. Thank you. May I have Dr. Sajja Padma's CV, please? Welcome, ma'am. It's so good to see your smiling face here.
Thank you, ma'am.
So, ma'am is the director of Pragati IVF and Laparoscopic Center, Rajamundry, Andhra Pradesh since 2001. She has established the first IVF center in Rajamundry, delivered the first ICSI baby in 2002, She was the president of Rajamundry Society 2015 to 17, organizing secretary for AP State Conference of APCOG for the year 2009, which was conducted at Rajamundry. She's been a faculty, attended many national, international conferences. She is an MD from Osmania Medical College, had certificate training course in infertility at National University Singapore and RCOG. She has training in infertility at Mount Sinai Hospital, New York, and member of ESHRE, SRM, and FOXY. Welcome, ma'am. We would love to hear a few words from you.
Thank you very much, Dr. Asha, for your nice introduction. And good evening, everyone. I feel really honored to join this webinar today, as it is started with eminent speakers like Dr. MC Patel, sir, and Dr. Padmaja Veeramachaleni, your former founder president of AP Chapter ISAR, and also our colleague Satyavati and many friends, and also our beloved teacher to share the platform, Dr. Ramadevi Garu, and senior colleague Dr. Raj Garu. And Shriyasri, thank you very much for making me the part of this webinar. And as all of us know, stillbirth is, as my previous Dr. Rajgaru and Ramadev madam mentioned, it's a nightmarish experience for the family and the women, and also for the treating gynecologists also. So every gynecologist or obstetrician, they do come across such scenario once in a while or on and off during her career. So whenever this nightmarish experience or difficult scenario happens, we should be ready with our own protocols and also guidelines to tackle the situation. Our responsibility starts from relaying the information to the woman and her husband and the relatives, and also with the bereavement care, and also safe delivery of the woman, and also we have to find the reason for stillbirth with the fairly good conclusion about the cause. So this is when this kind of webinars come into play to formulate good guidelines and also protocols for the young generation. This is how we should utilize such kind of webinars completely under the guidance of seniors and their experiences. Every young gynecologist or every gynecologist must have their own protocols and guidelines to tackle this situation. And as we all know, India is contributing very high in number to stillbirths worldwide, and we have to reduce that stillbirth rate. All of us have responsibility. So whenever the stillbirth happens, we should as a team, including pediatrician, pathologist, and geneticist, we should form a team and come to a conclusion, fairly reasonable conclusion about the cause of stillbirth, so that we can prevent some of the preventable causes in the next pregnancy. So that's how we should formulate our protocols and guidelines. And lastly, I would like to wish our
नमकीन खाने की इच्छा हो रही है, मिठू हो गया चाय।
Dr. MC Patel, sir, for his future candidature for presidential elections. All the best, sir. Thank you. Over to the session, next session. Thank you very much.
Thank you, ma'am. Thank you so much. Patel, sir, would you like to say something? Patel, sir? So, his net is creating a lot of problem. Hopefully for his lecture, it will be fine. Thank you so much, Raju sir. Thank you, Ramadevi ma'am, and thank you, Padma ma'am, for those kind words. And it's been a pleasure having you here. And with all your blessings, we proceed now for the scientific session. Our first lecture is on etiopathogenesis and management of antepartum stillbirth by Dr. Satyavati Srijana. And we have three chairpersons, Dr. Tirupati, Dr. Aruna Kumari, and Dr. Saraswati. Dr. Tirupati may not be able to join us right now. He can join later. So may I have the CVs of the chairpersons, please? Ma'am, just a minute. I need to introduce the chairpersons. Tirth, this is very dim. I cannot read it. Yeah, this is better. So our first chairperson is Dr. Stesh Sai Tirupati, a very avid academician, very interested in the well-being of his students. And he has a PG diploma in human rights, extra from his medical education. He's worked in the army as captain for 5 years, NSS program officer at SV Medical College, Tirupati, working as associate professor of Government Maternity Hospital, SVMC, Tirupati, and he's also a Lions Club member. So welcome, sir. His hobbies are teaching, fencing, driving, and technical analysis of NSC. Welcome, sir. Next, please. Next slide, please. We have Dr. Aruna ma'am, who is graduated from Rangaraya Medical College, Kakinada, University, first in panel MBBS. She has done her PG from PGI Chandigarh, ex-associate professor of GSL Medical College, Rajahmundry, senior consultant, Harsha Hospitals, Rajahmundry. Her areas of interest are infertility and high-risk pregnancy. He started the Rajahmundry Obstetric Gynec Society and conducted many CMEs and Andhra Pradesh State Conference in 2012 and 21. He is an invited faculty at many state and national conferences. Welcome, madam. Next slide.
Thank you, madam. Thank you for your kind introduction.
Thank you, ma'am. Now we have Dr. Saraswati, ma'am. She's an MD DGO, Managing Director of Mother and Child Hospital, Consultant Obstetrician, Gynecologist, and Infertility Specialist at Mother and Child Hospital, Kakinada. She's presented papers in AICOG and APCOG. Her areas of interest are high-risk pregnancy and infertility. I request one of the chairpersons to introduce our speaker. May I have the slide of the speaker, please? Ma'am, if Dr. Tirupati doesn't join in, please take over for the questions and also for the sum up. Dr. Saraswati and Dr. Aruna, ma'am.
Sure,
over to you, ma'am, now.
Dr. Saraswati madam is well known to all of us. She is a founder and director of Sujana Cosmetic Gynecology Center and Sujana Multi-Specialty Hospital. She is director of Sujana IVF Center. She trained in NUH Singapore, Genk University for Fertility Technology, Belgium at advanced course of micromanipulation and blastocyst culture. Madam started first cosmetic gynecology center in Andhra Pradesh, and she started the first HU baby center in East and West Godavari districts, Andhra Pradesh. And she is the first doctor to introduce blastocyst culture in coastal Andhra Pradesh, and first IVF and ICSI babies in both East and West Godavari districts. Madam, it's over to you. Today we are going to discuss one of the most unexpected adverse pregnancy outcome, that is the antepartum stillbirth. There is no universally accepted definition, same, and around 50% of them are unexplained. So it's very difficult to formulate any protocols of screening the high-risk pregnancy high-risk patients to prevent antepartum stillbirth. So today we have the eminent speaker Dr. Sachivati with us to discuss various etiological factors and how to manage the patient with antepartum stillbirth. Now it is over to Madam. Dr. Sachivati, you can start the.
Thank you, Aruna, for the nice words. Aruna, can you see?
Yeah, it's visible.
Okay,
and you're audible also.
Okay. Yeah, very good evening. Thank you very much, sir, MC Patel, sir, and Asha, ma'am. And very good evening, one and all. And my topic is etiopathogenesis and management of antepartum stillbirth. So, Yeah, let's get into the definition of antepartum stillbirth. So, but first, I want to start this presentation by asking you if you feel like there is something wrong with my slide. And most of you may be thinking that the term stillbirth is not appropriate for the antenatal period. So first, let us get into the definition. So as per WHO, the stillbirth is a newborn at or about 28 weeks of gestation with no signs of life at birth. As per British Journal of Obstetrics and Gynecology, it is defined as any fetal death after 16 weeks of gestation before the onset of labor. So in most high impact studies on antepartum stillbirth, authors have mentioned that fetal demise and stillbirth are terms that are being used interchangeably, and that the term stillbirth is being preferred as it sounds more sensitive when compared to the term fetal demise or death. So ultimately, death of a fetus after viability within the womb is considered antepartum stillbirth. And it is classified into early, intermediate, and late. Early is the death between 20 to 27 weeks of gestation, and intermediate is between 28 to 36 weeks of gestation, and late or term death occurs after 37 weeks. And etiologies of stillbirth. Etiology is due to either maternal causes, fetal causes, or placental causes, and sometimes it is unexplained. The relative frequencies of various causes of stillbirth appear to differ between low and high income groups and low and high income countries, and between the early and late gestation. And in low income countries, the etiology is mainly due to malnutrition, anemia, preeclampsia, and infection. And in high income countries, the etiology is mainly due to congenital anatomic abnormalities or karyotype abnormalities, placental problems associated with growth restriction, or maternal medical diseases. And according to gestational age, in early gestational stillbirth, the etiology is mainly due to congenital anomalies, infections, growth restriction, or any underlying maternal medical conditions. And late gestational stillbirth is due to maternal medical conditions or any placental factors like placenta abruptio placenta or placenta previa. And unexplained stillbirth, a fetal death that cannot be attributed to an identifiable fetal, placental, maternal, or obstetric etiology due to lack of sufficient information, or because the cause cannot be determined at the current level of diagnostic ability. It accounts for 25 to 60% of all fetal deaths. Congenital anomalies. 15 to 20% of stillbirths have a major malformation. This rate varies from country to country and greatly influenced by the availability of prenatal diagnosis and pregnancy termination. Fetal death can be attributed to a malformation if epidemiologic data support a relationship. The anomaly is rare in liveborn, but neonates often die. Malformations associated with the increased risk of fetal demise, but unrelated to structural chromosomal abnormalities, include abdominal wall defects, neural tube defects, Porter sequence, and lethal multiple pterygium syndrome, and amniotic band sequence, etc. These are some of the fetal anomalies: anencephaly, holoprosencephaly, omphalocele, and conjoint twins. They all underwent termination. And fetal growth restriction. Please note that the term IUGR is no longer being used. It has been replaced by the term FGR, or fetal growth restriction. Death of a growth restricted fetus is the second most common etiology of stillbirth. Placental dysfunction is a presumed cause of both growth restriction and stillbirth. The dysfunction may be related to maternal vasculopathies or intrinsic placental disease. So when there is FGR fetus, you see the growth of the fetus and the size of the fetus and the weight, and on Doppler you see umbilical artery Doppler, normal Doppler, abnormal, And uterine arteries, you see the notch abnormal, and ductus venosus flow and middle MCA. And in addition to this, we do the biological profile, fetal, and then NST. And infections. Infection accounts for approximately 50% of stillbirths in low and middle income countries, and 10 to 25% in high income countries. So the infection may directly affect either the fetus or placenta or the mother. Fetal demise as a result of severe systemic maternal illness, for example, pneumonia, sepsis, or severe COVID-19. And placental dysfunction due to placental infection or malaria. And fetal systemic illness, for example, E. coli, group B, Streptococcus, Zika virus, etc. And malaria is the common cause of maternal infection leading to stillbirth in endemic areas. Parvovirus and CMV infection are relatively common and should be considered in stillbirths of unknown etiology after autopsy. Genetic abnormalities. Most aneuploidies are lethal in utero. Some aneuploidies such as trisomy 21, 18, 13 and monosomy confer increased risk of fetal damage but can also result in live birth. So although death of a karyotypically abnormal embryo or fetus is most common in the first trimester, it can occur at any stage of pregnancy. Hydrops fetalis may be due to immune or non-immune etiologies and is often fatal. I'm sure you're all aware of this, so let's proceed to the next slide. Fetal cardiac channelopathy. Fetal death can be caused by variants in cardiomyopathy genes that result in channelopathy. For example, long or short QT syndrome. These stillborns do not have any anatomical anomaly, growth restriction, or abnormal CMA. So screening for hereditary channelopathies is difficult and requires gene panel testing. Such panels are not commercially available. Although gene testing for specific channelopathies is available. Example, long QT syndrome is often associated with KCNQ1, KCNH2, and SCN5A variant. Practically speaking, in our scenario, the diagnosis is supported by a family history of fainting or cardiac arrest without any obvious cause, and abnormal parental ECG findings are sometimes seen. So consultation with a genetic professional and cardiologist can be helpful. And placental abruption. Placental abruption does not always cause stillbirth. If the risk is highest when the more than 50% of the placental surface becomes separated, or when the abruption involves the central part of the placenta. And other causes like umbilical cord abnormalities, knot, torsion, nuchal cord stricture, prolapse, etc. And placental abnormalities like placenta previa, abruptio placenta, rupture of vasa previa, and feto-maternal hemorrhage. Feto-maternal hemorrhage, if it is sufficiently large, it will cause fetal death. So it has been reported up to 5% of the stillbirths. And what are the risk factors? Socio-demographic factors. Black race are at more risk than the white race, and significant life events like financial crisis, emotional disturbances, traumatic events, and the partner relations stress, all these increases the risk. And younger and older age. If the mother is below 20 years age, and if they're elderly above 35 years age, they're at more risk. And unmarried status also increases the risk. Parity and nullipara, primipara, and grand multipara are at more risk. Heat and environmental stressors, increased heat waves also increases the risk. Previous stillbirth, previous adverse pregnancy outcome, and individuals with a previous pregnancy, previous preterm birth, or small for gestational age newborn are at increased risk of stillbirth in subsequent pregnancies. Maternal medical disorders like diabetes and hypertensive disorders, and substance usage, thrombophilia, and obesity. And individuals with diabetes are at increased risk with stillbirth at or near term. the fetus of the diabetic, and it is due to two mechanisms. Fetal hyperglycemia and hyperinsulinemia increases the fetal oxygen consumption, which may induce fetal hypoxemia and acidosis if the oxygen needs are not met. Then second mechanism is maternal vasculopathy and hyperglycemia can lead to reduced uteroplacental perfusion, which may be associated with reduced fetal growth. Hypertensive disorders are associated with low-income countries. Placental insufficiency and abruption are the major causes of fetal death in patients with hypertension. Substance usage. In this, especially smoking. So there is a direct relationship between the number of cigarettes smoked and the risk of stillbirth. So 2 to 3-fold increase in the risk of pregnant individuals smoking more than 10 cigarettes per day. And the risk is much more higher when it is associated with alcohol consumption and when they smoke during first trimester of pregnancy. Obesity. Risk for fetal death, stillbirth, birth asphyxia are all increased in maternal obesity. Uterine abnormalities. Structural uterine abnormalities such as unicornuate uterus can be associated with cervical insufficiency, which can lead to pre-viable preterm birth. Amniotic band sequence usually causes a fetal deformation but may also result in stillbirth if the umbilical cord is constricted by a band. Here I want to quote one of my case. One of my patients had monochorionic diamniotic twins, and our chronologist diagnosed one fetus has multiple anomalies, most probably genetic, and other fetus is absolutely normal. Then we have we referred the patient to Mediscan Chennai, and there they diagnosed amniotic band syndrome in one baby, and the other baby is absolutely normal. Then I was praying all the time that the umbilical cord would get constricted by the band, but it never happened. At 24 weeks of gestation, she went into twin-to-twin transfusion, and they have done RF ablation for the anomalous child. But 1 week later, at 25 weeks of gestation, she went into spontaneous labor and expelled an anomalous fetus and delivered the viable fetus of 700 grams. And the baby was admitted to NICU at Mehta Hospital and discharged in good condition after 2.5 months. So we could prevent stillbirth. And fetal risk factors, multiple gestations like monoamniotic twins and twin-to-twin transfusion, etc. Male sex are increased less than the female sex. Platelet alloimmunization and postterm pregnancy. If the pregnancy is beyond 42 weeks, that also has, because of placental dysfunction, so increased risk. And what are the signs and symptoms? Decreased baby movement, fluid leakage from the vagina, and unusual discharge or bleeding. And this is a 35 weeks female. The female at 35 weeks came with loss of fetal movements. Then we sent for Doppler. So this is early diastolic notch and MCA, and umbilical reversal of flow in umbilical arteries. And on ductus venosus, there is a reversal of the A form. So immediately we have done the delivery, but after 3 days, the baby died. And this is another patient, very obese, on routine ultrasound. This is umbilical artery absent diastolic and MCA increased diastolic and uterine notch. But on ductus venosus, there is no reversal, no acidosis, and this child survived. Components of preventing stillbirth, Padmaja will be dealing with this. And management, confirmation and communication. Confirmation is very easy by ultrasound, and communication, which is very, very difficult. And especially they'll be very emotional if you once say it is the baby is dead. Then always, my opinion is always take a second opinion, either second scan or consult one of your, take help from one of your friends or seniors or colleagues or a psychologist, and then only You have to be very patient, sit together, talk to them. And usually when there is a problem occurs, so many people will enter into the situation. So all these, so what do you say, Aruna Saraswati? Evaluation,
Right.
then next, huh?
Yeah, it's very difficult situation. It's really
Yeah,
very psychologically traumatic for the patient and to the attendants and to the doctor also. So we have to be very careful while counseling these patients
yes,
and
yes,
attendants.
yes. And I feel we should not counsel them alone. Take somebody's help to share to share your stress and your emotions. Okay, and share the responsibility. That will share the responsibility also. If you
The
don't get,
parents should be counseled in a private area. The mob
yes,
should not be allowed to enter inside.
that is always not possible. That's why you should not counsel them alone. You should be at least take help from a radiologist or another optician or senior somebody, at least anyone, or a counselor, anybody. But you should be at least, if the mob enters, then you have to call the group or inform the police. That's it. That's it, na? Then evaluation and investigation, emotional stress, emotional support. Communication with bereaved parents should be clear and honest. You have to be very patient. The term baby or baby should be used in conversation. Terms such as fetus, embryo, or spontaneous abortion should not be used. And methods of delivery. The method and timing of delivery after stillbirth depends on the gestational age at which the death occurred and maternal obstetric history, like a previous hysterectomy or something, and maternal preference. Options of delivery include induction of labor or cesarean section. And screening for risk factors. This Padmaja will be dealing with this. And evaluation of the stillborn neonate. So thorough, when you get a stillborn neonate, thorough history taking and total X-ray fetogram and MRI and autopsy and placental pathology as well as umbilical cord and the membrane. If the cause is known, if it is due to fetal growth restriction, then genetic analysis and APA. If the cause is due to fetal anomaly, then genetic testing. If it is unexplained, then genetic analysis, APAs, KB smear for feto-maternal hemorrhage, and serology, etc. And if it is due to infection, cultures and serology. And maternal evaluation is also very important. Then look for diabetes mellitus, chronic hypertension, preeclampsia, renal disease, infection, SLE, or whether she is taking any medications also, medication history also you should take. And fetal and placental evaluation, weight, head circumference and length of the fetus, weight of the placenta, photographs of the fetus and placenta, frontal and profile photographs of whole body, face, extremities, palms and any abnormalities, and document the finding and abnormalities always. Obtain consent from parents for cytogenetic specimen. So acceptable cytogenetic specimen is amniotic fluid just before delivery and placental block, umbilical cord segment, internal fetal tissue specimen such as costochondral junction or patella. Skin is not recommended at all. These are collected in a sterile container, contains Ringer lactate solution and transferred at room temperature to the lab. And microanalysis, it detects the aneuploidy and smaller deletions and duplications. And if the patient can afford exome sequencing or whole genome sequencing. And obtain consent from patients for fetal autopsy. If no consent is given for autopsy, external evaluation by a trained perinatal pathologist is very, very important. Other options include photographs, X-ray imaging, ultrasonography, MRI, sampling of tissues such as blood or skin, fetal whole body X-ray, and placental pathology and umbilical cord pathology. Prevention, Padmaja's role, And management of stillbirth requires a multidisciplinary approach involving obstetricians, nurses, counselors, and other healthcare professionals. Thank you very much. Thank you very much, MC Patel sir and Asha ma'am and Sujay Sri, and thank you very much.
Thank you, Satyavati ma'am. Over to the chairpersons to please sum up, and then we can proceed to the next session.
Saraswati madam. Sachvati madam, it's really good elaboration of what is the underlying etiopathogenesis of the antepartum stillbirth, how to evaluate the patient, how to counsel the patient and the attendants, and after that, after the delivery of the stillbirth, how to evaluate the baby to know the underlying cause and what precaution to manage the next upcoming pregnancy. It's really wonderful lecture, madam. Thank you so much.
Thank you.
And at this juncture, I want to thank Dr. MC Patel sir, Asha madam, and Sujayashree madam for making me a part of this Happy Learning Masterclass 193 episode. Thank you so much. And MC, it's all the best to the Asha Jain madam and MC Patel sir for their future endeavors. Thank you so much.
Thank you, madam. Thank you.
Thank you.
Dr. Tirupati has also joined. I would like to expert comment from Tirupati sir, because he is also one of the chairperson for this section.
Good evening, sir.
Good evening. Welcome.
Really a wonderful class I heard, sir. Very good lecture. And stillbirth, every case we are struggling to convince the patients. The first question is why it has happened, what has happened, and another thing, the testing, everything, it is very costly nowadays, and many patients are poor who are coming for government hospitals. So this is the best class. What we heard, we can do the best, whatever we can do. Nowadays, we are taken from ICMR, from Tirupati itself, there is ICMR South India office. We are trying for this project on stillbirth. And if it is there, we can help many people. And thank you, sir. Very good opportunity I gave. Thank you very much.
Thank you, sir. Welcome.
Thank you, Sej Sai sir. Very good of you to join in even after having so much of exam whole day. Thank you so much, sir. Thanks for your dedication.
I requested him, even if you join little late, it will do, but you join and have your expert comment. And he have joined. So thank you. Thank you, sir, for the same.
Thank you, Aruna ma'am, for all the wishes. Thank you.
Thank you. All the best, ma'am.
So now may we have the CVs? Thank you, ma'am. May we have the CVs? Dr. Padmaja ma'am has asked me to make them really short because we are getting late. So,
Dr. Asha, are we doing it first or Dr. MC Patel is giving his talk?
Dr. MC Patel sir is giving his talk.
Okay.
So, but I'm going to introduce in very short.
Yes.
Okay. So, may I have the CVs, please? Tirth.
Yes, ma'am.
Please share the CVs. And one by one, very quick, because I'm going to give a very small lecture introduction. So we have Dr. Nirmala Devi Bachoti ma'am. She is the president of Eluru Society, a very simple and very kind person. Welcome, ma'am. Next, Dr. Narsinga Rao, who's the president of Vishakhapatnam Society. Welcome, sir, to this webinar.
Good evening, madam.
Good evening, sir. Good evening. You're driving?
No, my daughter is driving.
Okay. Welcome, sir. Thanks for the effort. And we have a third chairperson, Dr. Sujata ma'am, Dr. Sujata Velanki. Clinical Head and Fertility Specialist at Oasis Fertility, Vijayawada, Secretary of Vijayawada Society. Over
Good
to you,
evening, ma'am.
respected chairpersons, to introduce MC Patel sir and the topic and take the program forward. Over to you. Please share MC sir's CV. One of the chairpersons, would you please introduce, sir?
Yes, I'm Dr. Nirmala Devi from Eluru, madam. I'm
Welcome,
UGS
ma'am.
president,
Welcome.
and I'm very happy to introduce Dr. MC Patel, sir, who is very well known to everybody. And he is a consultant obstetrician, gynecologist, and medical legal counselor, vice president FOXY 2018, organizing secretary AACOG 2017, chairperson ethics and medical legal committee, FOXY 2011 and 13, honorary secretary, state organization of gynecologists and obstetrician of Gujarat 2022-24, organizing chairperson Conference 1918, honorable member National Inspection and Monitoring Committee, PCPNDT, Government of India 2015, honorary member State Supervisory Board and PNDT Committee, Gujarat State 2005-9, President Ahmedabad Obstetric Gynecological Society 2010-11, honorary member National Managing Body Indian Red Cross Society, headquartered 2019-22, National President National Medicos Organization 2016-18, President IMA Ahmedabad branch 2007-8, honorary surgeon Indian Red Cross Eye Bank, collected more than 1,000 eye pairs, organizing chairperson Vivekanand NMO Conference 1913. So I'm very pleased to introduce sir, and I wish him all the best in his future endeavors. Thank you.
Please stop sharing so that sir can share.
Is my screen seen?
Yes, sir. It is seen, sir. You need to make it full screen. Yes, full screen.
Full screen. So in my computer,
Yes,
it is in full screen. Is it there?
It is full screen.
Okay.
Yes,
okay.
sir.
So thank you, madam, for kind words. Reading from Statue of Unity, tallest statue of world, and we all are proud of that statue. And before I go to the subject, this is my humble appeal.
So you have not shared sound. You haven't shared sound, sir.
Sound is not heard.
No, sir. You need to, when you are sharing, stop share, and when you share again, shares with sound.
With sound, where it will be, you will have to guide me.
Sir, on share screen, choose the program that you want to share.
Share screen, then
Yes.
Share sound. Yes, option is there. Share sound.
Yes. Just share sound kar dijiye.
Okay, share sound. I did it.
शुभं
Sound is there now.
करोतु
It is okay.
आरोग्यं सुखसम्पदम्.
Respected seniors and dear colleagues, serving Foxy for years together. On this auspicious day, with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President, year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना. So please endorse my candidature for post of President Foxy, election year 2024. Election would be from 1st August to 10 August, but before that, now process of nomination is on and it is up to 31st of May. So President and Secretary of Joining Society who have still not nominated, then please nominate me for the post of President Foxy and Dr. Asha Jain for post of Chairperson, Food, Drugs and Medico-Surgical Equipment Committee, Foxy. Usually we go with this IUFD, care in the aftermath and beyond. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this webinar and President and Secretary of all the society, all the guests, faculties who have joined this webinar. So, as far as case of IUFD is concerned, they are potential as far as litigation part is concerned. Let us see, this is real happened case in city of Ahmedabad only. It was very regular antenatal checkup, sonography every time, told everything is fine except polyhydramnios. At 34 weeks of pregnancy, during routine antenatal checkup, it was found to be a case of IUFD. So, this section was advised, pre-operative investigations were done, and blood sugar came out to be 432 milligram of dilution. And before that, blood sugar was never advised in this very case. So, notice was served, case was filed, and compensation demanded 1 crore. Still, case is to be decided. But in this situation, it becomes very difficult for us to face in court of law because this gynecologist never advised blood sugar during antenatal period till 34 weeks of pregnancy, and ultimately she went with IUFD. Let us see one more case. It was again unbooked patient, primary 34 weeks of pregnancy. It was the very first visit of this patient with gynecologist, and he came to know that she is case of PIH. So he advised all necessary investigation and treatment. But unlucky on part of patient, very next day, she developed abruptio placentae with intrauterine fetal death. Cesarean section was advised. Relative opted option to go for second opinion in nearby town. Patient was brought to nearby town and went to surgeon. Cesarean section was done. Again, unlucky part on patient. She developed atonic PPH and ultimately hysterectomy was done. Imagine the situation, primary patient, intrauterine fetal death and hysterectomy. And case was filed, this was served. Allegation to first doctor was not properly managed to prevent abruptio placentae and intrauterine fetal death. And allegation to surgeon was not tried to prevent PPH and atonic PPH was not managed properly. Luckily, I was defending both of them. Ultimately, we won the case, but it was difficult to explain in the court what is abruptio placentae, how IUFD occurs in abruptio placentae, what precaution one can take not to end up into abruptio placentae, what is PIH, and court was convinced because with very first visit, when she came to be known as a case of PIH, doctor has advised all necessary investigation and treatment, but it was unlucky on part of patient, she developed abruptio placentae. So gynecologist was out of picture. Now, as far as role of surgeon is concerned, when she developed atonic PPH, he had taken utmost care to control bleeding with oxytocin, ergometrin, prostaglandin, stepwise devascularization, compressive suture. He had infused 3 units of blood also. But in spite of all these efforts, bleeding was not getting control, and ultimately hysterectomy was the only answer to save life of patient. So hysterectomy was done. And in court, we could convince court that what is atonic PPH, how it occurs irrespective of mode of delivery, and what one can do or what one should do to manage atonic PPH. So our surgeon friend had managed that very case, way in which any prudent doctor would have managed. So we won this case, but it becomes very difficult in court of law when there is sudden IUFD in any given situation. So many times it happens. But how, doctor? You said everything was all right just 10 days back, and it becomes very difficult to convince patient, rightly mentioned by Dr. also. So it is a great physical, emotional, psychological, and social trauma for parents as well as family. So if you go with the statistic, worldwide stillbirth rate has now, of course, it is falling. It was 35 per thousand in 1980. It has come to 15 by 1,000 by 2015. But government is very interested because as far as Indian contribution is concerned, it is 23rd per 1,000. And by 2030, WHO and central government has given us a target to come to infant mortality rate 12 or even less than 12. Of course, there are few states in southern India, they are already having this good rate. But at the same time, in northern India and particularly northern eastern India, still maternal mortality as well as infant mortality rate is very much high. So we should be very careful as far as part is concerned. As far as today's my talk is concerned about IUFD, confirm the diagnosis, why this happened. And Satyavati madam has rightly and very aptly discussed the etiology and management part. So I won't go into the detail, but I would like to mention in 50% of stillbirths are preceded by decreased fetal movement. So in any given situation, when patient complains decreased fetal movement, it should be taken seriously, because if patient has complained and no proper action is taken, it becomes a potential situation as far as litigation is concerned. Sometimes fetal movement perceived even after intrauterine fetal death by patient. And as far as scanning part is concerned, it correlation at false positive rate up to 30%. Auscultation may be inaccurate, and with inaudible fetal heart sound, many a time baby may be viable. So gold standard is ultrasound, very nicely mentioned previously also, because it shows about all the details about fetus as well as placental localization and retroplacental bleed or clot. And as far as fetal part is concerned, presentation, approximate weight, Spalding sign, hydrops, and gross anomalies. So ultrasound is gold standard as far as confirmation of diagnosis is concerned. Clinical evaluation of the patient is very much must once we diagnose IUFD. So exclude immediate severe maternal morbidity. If at all patient is having acute abdominal pain, rule out abruption. If vaginal bleeding, if patient is in labor, or if it is P-prom, or if it is an obstetric emergency like eclampsia or maternal collapse, we have to manage situation accordingly, not to end up into any kind of litigation, because all these conditions, if we have not managed properly, these are the potential situation for medical legal issue. As far as evaluation of probable cause of intrauterine fetal death, Madam Satyavati has already mentioned, so I do not go into detail. But as far as communication is concerned, it is a very important part how to break this bad news to the patient, to the next of kin, and relevant authority. Because in few of the institutions, there is a protocol to inform head of the unit, head of the department, and head of the institution. So if it is protocol, then we have to inform authority accordingly. But as far as information to the patient and next of kin is concerned, it is very important part. Because most terrible thing that can happen to an obstetrician to declare bad news. Because where do we go from here? It is very important part. So in this situation, role of RUS team is there. So what is RUS team? So in any given situation, whenever any member of a society is in trouble, he can call any member of RUS team, and whosoever is available, they will be at your rescue. Say, for example, in surgical emergency, if it is a case of PPH and internal iliac ligation is needed, and one is not well versed with internal iliac ligation, then in this situation, a member of RUS team could be at your rescue. And at the time of declaring bad news like this IUFD or stillbirth, or at the time of mob violence, or at the time of facing litigation. So as far as the role of RUS team is concerned, it is very vital at the time of communication with relative about this bad news. हम आपके बच्चे को बचा नहीं सके. It looks simple in Hindi film, but it is not that simple in our day-to-day practice. So inform condition from time to time. If we are dealing with a high-risk pregnancy cases, severe GDM or uncontrolled GDM, in this type of situation, we have to counsel patient and patient party, and we have to.
Battery is low.
Only 1 minute.
Running low.
Only 1 minute.
We tally this. Maybe voice going.
Voice and poll is ఇప్పుడు ఇంకా ఇమీడియట్ పార్టిసిపేషన్ ఏం లేదు కదా వద్దని వచ్చాడు మీకోసం ఏదో అడ్వాన్స్ ఆఫ్ మాట్లాడడానికి
Sorry for interruption. So inform condition from time to time is very much vital part as far as this type of situations are concerned. For example, if it is a case of GDM, severe preeclampsia or eclampsia, severe IUGR, abruptio, in all these conditions, proper counseling is very much must, not to end up into litigation in future. And if at all we end up into litigation in future, it becomes good defense in our favor. And whenever we have to declare bad news, it should be by senior most person and not to the junior. It should not be allotted to any junior residents or so. It should be declared by senior person only. This together with RUS team is available. So if member of RUS team is there with you, it becomes easier, or it becomes many times comfortable to in this type of situation. Be polite and sympathetic, but assertive at the time of declaring bad news. And be prepared for knee-jerk hostile reaction, because we never know what could be the reaction on part of relative of patient when we declare this bad news. Be prepared for mob frenzy also. Do not lose patience, because there will be so many questions on part of patient and patient party, but we have to answer all those questions very patiently and do not lose patience. Do not blame each other. When more than one person is involved in the treatment, please do not blame each other, because we lose sympathy from patient party and it becomes very difficult for us to face in court of law also. So as far as breaking of bad news is concerned, usually it should be in a private room, not in a general room, or not in a lobby, or not in a reception area. It should be in a private room. Arrange interpreter if necessary. Avoid using family members as interpreter, because many a time what family members interprets to the patient, we do not know. So if at all interpreter is required, it should be a party. Discuss care and decision with both parents and or a support person, and document plan of care. Now, how we are going to manage that case of IUFD, we have to discuss with patient and patient party, and we have to mention everything about that. Nurse, registrar, and others members of multidisciplinary team should be available to give parents further information on diagnosis and outcome. The patient and patient party are free to discuss this type of situation with any of our staff. Also, as far as management of plan is concerned, delivery and further investigation, Madam Satyavati has already discussed this in detail. So I do not want to go into detail. But as far as management plan is concerned, clearly document in chart with consultation with parents what is your further plan of management as far as delivery of this IUFD baby is concerned. Include their wishes with regard to meeting members of multidisciplinary, just I mentioned prior also. Management may be expanded or involve medical induction of labor as per condition of patient. Urgent delivery is needed in case of abrasio, APH, preeclampsia, eclampsia, sepsis, PRM, because this is very much required to be documented in records also, because whenever we are facing litigation in this type of situation, we can prove that as soon as we came to know that it is a case of IUFD, we had taken utmost care of that very patient in given situation as any prudent gynecologist would have taken. And as far as expectant treatment is concerned, more than 90% women go into labor within 3 weeks of IUFD. It is known fact, but there are some disadvantages as far as expectant treatment is concerned. Because 10% patient may go in DIC in 4 weeks and 30% after 4 weeks. So if at all we are waiting for expectant treatment, then it should be well counseled to the patient that we are waiting and these are some probable risk involved. So we have not to face any kind of problem as far as litigation part is concerned. May have difficulty in identifying the sex if we wait, because baby will be macerated naturally, and value of post-mortem examination may be decreased if we go with expectant. These are very important points as far as legal part is also concerned, because if we have gone with expectant treatment and when we face this situation, there could be question on part of prosecution. If it is delayed more than 48 hours, do not add to any risk. But if no other associated complications like sepsis, preeclampsia, placental abruption, and membrane rupture. So, as far as care in labor room is concerned, she should be given a private room and display a hospital pregnancy loss symbol on door of that room. So, no other patient or co-patient, relative of co-patient should disturb that patient or patient's relative. Allocate one nurse to family for intrapartum care. All these are very much important points as far as if at all we face any litigation, then it shows our concern that we have taken utmost care of that very patient in that given situation. Prepare patient for appearance of baby after birth, because we know many times baby may be macerated or skin is easily peeled off. So we should make them prepared to face or as far as appearance of baby is concerned. Discuss about parents seeing and holding baby after birth, and check blood count, group and coagulation screen have been done in at least last 24 hours if we are going for expectant treatment, and use partogram during labor. All these points are very much important, because whenever we are facing in court of law, these important questions are asked on part of prosecution. As far as care of stillborn baby is concerned, get verbal consent for initial examination. Straightway, you cannot submit that baby for examination to anybody. So, initial proper consent from patient and patient party is very much important. Offer parents opportunity to dress and hold the baby if they are keen, because we never know what is the sentiment on part of that family who have lost their baby. Assist parents in taking photographs of baby if they are willing. Then cord blood if patient is RH negative. General appearance of placenta, weight, cord and membrane, and any retroplacental clot, we have to mention everything in our record. It is very much useful when we are facing litigation. Number of vessels, any nodes, cord around neck, tight or loose, it is also to be mentioned, because if at all questions come, why this IUFD happened, then we may have some clue to answer that question. Sample of placenta and or cord for cytogenic testing as per local protocol before placing in formalin. Mentioned by Satyavati madam also, as far as this testing and sample of placenta is concerned. Placental swab obtained from fetal and maternal surface is also very much required to manage a patient further. Placenta sent for histology with appropriate request form is also one part of the management. As far as mementos are concerned, so we have to offer all this, that is hand and footprints, lock of hair, name band, cord clamp, memory box, photographs, and whole body X-ray infantogram or ultrasound scan. And if patient or patient party are interested to have all this document, we are supposed to give all those documents to. As far as fetal autopsy is concerned, this is one more area. We should offer them fetal autopsy, but ultimate decision is on part of patient and patient party. If they give consent for fetal autopsy, then only we can subject fetus for autopsy. It, of course, it helps in diagnosis, cause of death, or add information in 20 to 76% of the cases. May change in final diagnosis or affect genetic counseling also. In clinically unexplained stillbirth and relevant condition at death, classification is recommended. As far as this autopsy part is concerned, if parents are not ready to give consent for autopsy, then we can explain them about full examination of that baby. But again, for that also consent is very much required. Examination by neonatologist, pediatrician, by pathologist. But for that, proper consent for external examination and consent for clinical photographs, etc., is very much must. Do not forget all these vital parts, that beware parents need lots of support. Each person is different and will go through their own grief, because own has their own sentiment when facing this type of situation. And you can't do anything to make it better, but you can be present all the time with them to support them morally. As far as documentation part is concerned, this is vital part, because these are the cases which are potential as far as litigation is concerned, and we can prove ourselves in court innocent only by proper documentation. So record keeping is very much must. As far as OPD case papers are concerned, if it is book patient, then all the OPD case papers indoor from admission to discharge. If patient is book patient, it's fine. If it is unbooked patient, if patient has taken treatment from any other hospital, then we have to ask for those records. And if patient do not have record, then we have to mention, because many a time patient is brought in an emergency, and on our examination we may found that patient is having UFD. As far as documentation checklist is concerned, as far as maternal part is concerned, physical examination, history of comorbidity, emotional status, it is very important part. And as far as scanning part is concerned, presentation, placental position, gross anomaly, amount of liquor, placental site, whether IUFD is fresh or it is old, it is to be mentioned in our record. As far as baby part is concerned, after delivery, gender of baby if detectable, birth weight, gestational age, date and time of birth, and if it is twin delivery, then we have to label twin 1, twin 2 with placenta, cord, etc. And photo documentation is also very much must, because whenever we are facing litigation, all these measures which we have taken shows our impression that we have taken utmost care of that very patient. As far as follow-up treatment part is concerned, protocol part is concerned, So as per protocol prevailing in your institution where you are working, you have to observe as far as labor ward register is concerned, stillbirth register, stillbirth certification, notification. It is also a very important part because under Birth and Death Registration Act, we are under obligation to notify that event to the appropriate authority. And there are 3 prescribed forms. Form 1 is for live birth, Form 2 is for death, and Form 3 is for stillbirth. So if we are notifying stillbirth, then we have to notify it in Form 3, which is prescribed form, and it is available on website also. Ensure discharge summary provided, it should be very accurate. So we have to follow all this protocol. As far as preventing future recurrence is concerned, it is very much must, because if at all it reoccurs with your, when patient comes to you only in successive pregnancy, and if it reoccurs, it becomes much potential as far as litigation is concerned. So preventing reoccurrence is very much important, because this is a common statistic that in 592,000 stillbirth per year in India, of course it is little old statistic, 50% are intrapartum and 40% are growth restricted. So in all these situations, can we prevent this? This is a vital question, because if we have to achieve that goal given by WHO and central government by 2030, then we should be very careful as far as this part is concerned. So as far as future pregnancy is concerned, strengthen antenatal clinical screening and boost them morally also. And they should be very particular as far as proper antenatal care is concerned. This certification, what was the cause of IUFD in that very pregnancy, we have to explain to the patient, and patient should be serious about all this antenatal checkup and all the investigation we advise and all the treatment. Antenatal pickup is a key to management, and clear referral algorithm is very much must. And it should be protocol-based management, because if we have observed any guideline or protocol, it shows our concern to take utmost care in court of law whenever we are facing litigation. Skill training and equipment for management is very much required. And just I mentioned prior also, moral support to the couple is very much important, because once they have faced this bad incident, they will be very disturbed mentally also, and they need moral boost up, but not only from doctor or clinic, but it should be from other family members also. As far as evidence factors,
excuse me, sir, we are overshooting the time, requesting you to actually wind up, because a lot of this will be taken up by Padmaja ma'am.
Okay. So I will be very quick. So our ultimate goal is to 12 infant mortality rate is concerned by 2030. So you were born silent, perfect and beautiful, still loved, still missed, still remembered every day, still born, but still born. And all these situations are concerned. They are potential cases as far as litigation is concerned. So this is a very vital question used in court of law. Was it preventable? And if you cannot say no, one more question is will be coming. What did you do to prevent it? To prevent IUFD or stillbirth, what measures you have taken should be well documented. And why you couldn't prevent it could be one more question. And did you diagnose IUFD or stillbirth well in time? And did you manage way in which any prudent doctor would have managed? So if we answer all those questions, we could be out of problem as far as legal part is concerned. So these are the vital areas: failure in diagnosis, delayed in diagnosis, improper management, and reoccurrence. Because this is common allegation, no proper care taken to avoid reoccurrence. Because every IUFD cases are potential and looks like avoiding medical legal problem in our practice, difficult balancing act, not at all. What to do and how to prevent it? Practice foreseeability, that is anticipation, good communication and proper consent and proper documentation, and we will be simply through. So as far as high risk pregnancy part is concerned, whether it is GTM, hypertensive disorders in pregnancy, severe anemia, severe IUGR. So these are the potential the conditions which can enter into IUFD. So we should be readily available to deal with intensive care in this type of situation. So proper counseling is very much required, and it should be in a very simple language. No rosy picture about result, no tall claim, because in our obstetric practice, we consider result like Aishwarya Rai, but it may turn like this at any time. Proper communication and proper documentation is very much must, because records are always at your rescue. So antenatal monitoring and labor ward monitoring, it should be well recorded with all the records. So it should be up to date, what was done, nothing was neglected, and given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court, because doctor is bound to produce record whenever asked by the court, and if he doesn't, then adverse inference might be, and good record is defense, good record is no defense, good record is no defense. And it is my experience during my medical practice, we doctors are very poor as far as record keeping is concerned. It is always a way to conclude, always confirm IUFD by ultrasonography. Breaking bad news of IUFD should be done very carefully and competently. It can help us avoid a lot of medical legal issues that can develop with cases. Investigations are done primarily to find cause of death. In spite of all test causes are not found in 25 to 60% of the cases. History taking is most important part of evaluating case of IUFD. Vaginal delivery is preferred route unless it is contraindicated, and use of prostaglandin with caution in scarred uterus with IUFD is very important. Cytogenic evaluation will be helpful wherever where no apparent cause is found. Postmortem may be advised in certain cases, and fetal autopsy can provide insight as far as this cause of IUFD is concerned. Be very vigilant in next pregnancy. Continuous support and reassurance is required in next pregnancy. And in any case, never take pregnancy beyond 39 weeks of pregnancy with history of IUFD. So these are some guidelines not to attempt into problem. Pregnancy and labor role profile and protocols to be strictly followed. Protocols and checklist, proper counseling and proper consent, proper documentation, multi-speciality approach whenever required, take help of professional colleague, no compromise with statutory requirement. Professional indemnity is very much must in era of CPA, and be vigilant in your practice. Comply with the provisions of law. Formation of local level surgical team, I have mentioned there also. Take medical legal advice from point one if at all it is required. This gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. Have some basic legal knowledge and always obtain medical legal advice whenever you are in. So God bless you. Have a litigation-free medical practice. All the best, because in spite of all these professional and occupational hazards, our journey to serve and mankind is always on and on. If you want to sleep like this, take tender care of your patient. Comply with the standard protocols when you are dealing with high-risk pregnancy cases. Pray our Almighty God before going to sleep and keep my visiting card below your door. परेशान हो सकता है, लेकिन पराजित नहीं. And this is how we can be expert. Thank you. With regards, salute to all, and again seeking your blessings and support for post of President Foxy election year 2024. Thank you very much. Please do not assume. Please ask if any query, any question, if time and chairpersons permit. Thank you very much. And sorry for overshooting little more time.
Thank you, sir. Requesting chairpersons to say a few words before I introduce the panelists.
Yeah. Thank you, sir. Good evening, ma'am. Good evening, MC Patel, sir. This is Dr. Sujata Velanki from Vijayawada. Sir has aptly described about the importance of medical record keeping, and the most important thing that I feel that we should pick up is the photo documentation of the babies. And when we are addressing this antepartum stillbirth rate, we should understand the causes, and the best part is to advise the investigations and treatment, whether the patient gets it done or not, like whether they're affordable or not. We need to put it and document. Documentation is very important. Very nicely put it out, sir. One question I have over here, like how do we look at the socioeconomic factors of female feticide coming to us with a stillbirth to the clinic, and how do we get ourselves covered when you notice and document this component?
At what gestational age it has happened is very important. So if it is after 34, 36 weeks of pregnancy, it usually doesn't matter. But if it is nearby 11 or 13 weeks of pregnancy, and if we may call it abortion also, and if it is a female fetus, and when there is a history of previous 1 or 2 female child or children with that very patient, then it becomes a very vulnerable position for us also, because appropriate authority of PCPNDT may raise question that it could be a selective feticide. So we should be very careful in this type of situation, whether patient had been sonography anywhere, or whenever this type of case we are attending, say our patient comes with labor pain or so, or bleeding PV or so. So during that time of taking history, we should take history that whether a patient had been to anywhere for sonography or so, and patient is having 1 female child or 2 female children or so. In this situation, we should be very careful, because it is all likely that patient might have gone somewhere and it could be selective fetal female feticide. Because patient may take abortion pill over the counter and take medical pills and comes with bleeding PV or pain in abdomen also. So in this type of situation, proper documentation is very much must.
Thank you very much, sir. And over to you, ma'am.
There is one question for Saraswati, ma'am. Dr. Chilappan has asked, can we diagnose long QT at anomaly scans? Saraswati, ma'am, are you there?
Yes, sir. Yes, madam.
Yeah, so that is what he has asked, Dr. Chilappan.
Dr. Satyavati, long QT interval on, I don't...
Doctor. What is your doubt, madam?
No, not my doubt. Dr. Padmaja, I would request you to take it in the panel, okay?
Okay, madam.
Should I introduce the panel now?
Yes, madam, please.
Thank you so much. I'm really sorry. I have to hurry things up because our Zoom link will end at 8:30. So requesting for a rapid fire team, would you please share the CVs? And make it really quick. So we have Dr. Padmaja Virmachnani, ma'am, a very senior consultant from Vijayawada, much loved and very well known to everyone, very known for her academics. We have as experts Dr. Neelam Agarwal, who is the president of Stillbirth Society, Dr. Tamkeen Khan, who is the secretary of Stillbirth Society. We also have Professor Usha Prasad, ma'am, a senior gynecologist from Visakhapatnam, Professor N. Uma from Visakhapatnam, Dr. T. Padmaja from Rajamundry, Dr. K.V. Gayatri from Vijayawada, Dr. P. Pavani Manikya from Vijayawada, Dr. Mongol Chanu from Vijayawada, Dr. Baby Shalini, Secretary Chittoor Society, and Dr. B. Rao Bahadur from Vijayawada. So over to you, Padmaja ma'am. I've really made it quick and you can take over and take the panel forward. Please cover the question that Dr. Chilappan has asked.
Yes, we'll try, madam. I thank Dr. M.C. Patel, sir, Dr. Asha Jain for their untiring efforts in successfully conducting so many webinars. Getting one webinar ready with the panelists itself seems like such an uphill task for me. And mm, we'll go, and I thank all my panelists for readily agreeing. And this panel is totally, none of them know any of the questions because I was working on it till now. Okay. So everyone has been talking about what a shattering event it is. And after listening to Dr. M.C. Patel's talk, we know that we are also getting nightmares. But what we remember is the sadness and the loss that the couple feel, which they need to blame someone. And the soft target becomes the doctor. And the July, in fact, is a month that is called the Bereaved Parents Month. So this is a statue that shows the feelings, and it is there in Geneva. The sense of hollowness and the low feeling that they go through. And when you look at the stillbirths that are occurring, you can see the bigger dots are in India. So we have the highest number of stillbirths. That's also because we have one of the highest number of births. And those facts might look very hypothetical till we realize that globally one baby is stillborn every 16 seconds, nearly every 4 every minute, 200 every hour, and 2 million in a year. And in of these, 84% are from low and middle income countries. And since 40% occur in labor, and most of the time we concentrate on delivery, childbirth, and the precautions that happen in labor. But we need to remember that 60% of these stillbirths occur antepartum, and quite a large number of them are preventable with giving good quality care and support systems. So I thank Dr. Neelam Agarwal, who's the president of Stillbirth Society, and Dr. Tamkeen Khan, who's the secretary, and all my panelists for being with me as we go through this journey. So, as we said, stillbirths in India. Dr. Bahadur, do you think all over the country the stillbirths are the same?
Good evening, madam.
Good evening.
I don't know. It's not same in, and I mean to say stillbirth is not that it is located to any country as such, but maybe reporting in some countries is done on a meticulous way. That's why it is well documented that we have more stillbirths in certain areas. But geographical variations, maybe they may not be because of genetical evidence. That may be one of the reason why stillbirths may be in some localities.
So this was a survey done from the annual health survey of almost 8 lakh women in India from various states. And as you can see, in different states, it varies as little as 5 per thousand to as high as 14.8 in Uttar Pradesh. So overall, I think this is quite a reflection about the type of antenatal care that women get. And as Dr. M.C. Patel was telling, in the Northeast, in Assam and all, there is a pretty high stillbirth rate. So, Dr. Pavani, can you quickly enumerate what are all the causes that could lead to? So, in an antepartum patient, if these causes are there, we are going to be on a high alert for stillbirth.
Padmaja, just a small doubt. Recently, I've been going through the stillbirth rates in the states of India. To my surprise, I saw that in Assam it's less. Surprising.
This was one of the papers that is very recent, 2022.
Yeah, very recent. For what reason? And I saw Kerala, and it is 5 and 6, and Andhra is okay, not so bad. We are in the 20-30 single-digit figures.
Okay.
in Andhra Pradesh.
Okay.
Thank
So
you.
Pavani, you were telling me about the
Hi.
causes.
Thank you, ma'am, for giving me the opportunity. The pregnant women then comes to us in the first visit itself. We like to categorize the women into low risk and high risk, and this stratification goes on throughout the pregnancy in first trimester, second trimester, and third trimester. In the first trimester, based mostly on the history, like age, her previous pregnancy status, her chronic conditions like hypertension, pre-existing diabetes, her autoimmune history, like having an autoimmune history like SLE or chronic kidney disease, etc., or previous pregnancy history of losing, like having stillbirth or preterm deliveries due to preterm preeclampsias or severe IUGRs, or losing pregnancies in very early stage, like around 10 weeks with recurrent loss and having APLA syndromes. And also her parents' history also matters when it comes to preeclampsias. That's how we categorize, and also the infertility status and the mode of conception, like when mother conceives with assisted reproductive techniques, and also when the current pregnancy has high risk factors like twins. All these pregnancies are considered to be high risk. Even if the pregnancy is spontaneous, if the gap between the pregnancies is nearly around 10 years, then also the pregnancy is considered as high risk.
Thank you. And as you can see, just because they're coming from a high socioeconomic status, it doesn't mean that stillbirths don't occur. And in fact, one of the scary things is umbilical cord complications, which are not very predictable, that can happen universally anywhere. And even in the high income countries, with increasing obesity, increasing chronic hypertension, placental abruption can happen. Malformations are uniform everywhere. Infections, different types of infections, but the big chunk that we have is placental insufficiency. So we need to be alert about all these conditions. And as Pavani was telling about the age, Dr. Chanu, could you say what is the implications of the age? How should it matter what age the mother is?
So, thank you, ma'am. Extremes of ages, madam. So, like teenage pregnancies, they are more at risk of means all pregnancy complications. Most of the pregnancy complications, even stillbirth, they are not prepared for the pregnancy, and they are not educated well also. And even as the age advances, so they are more prone, they become high risk, and infertility issues are more, and then IVF pregnancies are more as the age advances. And so in the extreme of the age, they have these risks of stillbirth and other medical complications are increased, madam.
So as you can see, Dr. Chanu, so what is the best age you suggest to have a baby, seeing this U-shaped curve?
The base is, according to Sparrows, is given as 22 years. So like, so after 20 means like the girl becomes 22 years, that is after 20 years, they are means like 21 years, they usually, their body, reproductive organs and the whole body of the woman, the maturation is there. So before that, there is, the girl is still developing, she is growing. So her body is not fit to, not ready to conceive. So if before that if pregnancy conceives, then she is also growing, and her baby, she is actually not ready to support the baby. So more complications are there.
As you can see, the best age to have a child is between 20 and 35 years. So women need to pack in their reproductive potential based on the number of children they want to have, how early they start and when they stop it, because not only is it more difficult to bring up a child, it is also very difficult to carry a child. And Dr. Usha, could you comment on a woman who is pregnant? Where is she better off, in rural areas or urban? So is there a divide between the two?
Actually, we cannot say that someone is better off in an urban area or a rural area, but the kind of care that is given to her is more important. Actually, in a rural area, as she was commenting on age, child marriages are common. So we don't want teenage pregnancies. They are the government of India is trying to put a cap on that. And also the kind of care that is given to her is important. Nowadays in Andhra Pradesh, at least we are giving home visits and intensive monitoring and all. And one of the important factors that was found is the number of antenatal checkups. If we have reduced the number of antenatal checkups, it was found that there is an increased risk of stillbirths. So that is one thing we need to keep in mind. And nutrition, they said that there's an also a condition like energy malnutrition is there. Folic acid, they found in a systematic analysis that there was not much of difference, but nutrition is very important to prevent stillbirth. So if this kind of care is being given in a rural area also, then we cannot say. Because if a person is more educated and then they do not concentrate on their health and antenatal care, then stillbirth rate will be increased even in educated people.
Yeah, but comparatively saying, if you look at these statistics that are there, in rural areas where there is lack of access to quality antenatal care, and when there are no strong referral systems for timely access to emergency section, then also here
Yes,
it is not antenatal, it is
that's what I said. If you take the situation in Andhra Pradesh, there is an extensive support system for the rural area also. So it doesn't, geographic location doesn't affect, but the quality of care that we are providing, that makes a lot of difference. And in general, that's why rural area, there's no access to proper care. So that's a long-standing issue.
And Dr. Umar, in the history taking, do you think we should ask about the education status of the woman? Will it make an impact?
Yes, of course. Are you able to hear me?
Yeah, Dr. Umar, please.
Yes, of course. Because an educated woman naturally knows how to carry herself and about the nutritional status and about the checkups and the investigations. Naturally, uneducated people, they don't bother, even if you say about the investigations part also, and they don't really come back for the checkups as we ask for them. So naturally, there is a difference with educational status and education.
So there is not just a hypothetical one, there is definite evidence to show that when their level of education is tertiary care and above, the stillbirth rates are much lower, only around 2.2% compared to illiterate having higher. This is not always just based on the education, it also is based on, as Usha was, Prasad Garu was telling us, on the level of access to healthcare. And antenatal care in areas, Dr. Gayatri, it is not available to all people all over the country, in every nook and corner, antenatal care. So do you not think that the healthcare workers, we should rely on them? How can we get them to sensitize women to prevent stillbirth? Dr. Gayatri?
Yes, ma'am. Thank you for giving me this opportunity. Actually, in India and especially in Andhra Pradesh, there are more emphasis about this antenatal care. It's not only that patient approaches a doctor, but all the healthcare ANMs are sensitized, and they approach even the homes, and they check the blood pressure. They check they ask about the tetanus toxoid injections that has been given or not. So every healthcare worker is being sensitized to approach, and there are been targets which have been fixed to them. So because of this, as Usha ma'am was telling, that the quality of care in Andhra is much more improved. So maybe that will decrease the level of the stillbirths in any state or any place.
So it is only when the antenatal visits are much lesser than 4, more than 4, invariably they get covered, because they're also given the protein supplements and the iron supplements that are being given. So one of the simplest tests that we do and we always say is about anemia and hemoglobin. Is Dr. Padmaja around? I did not see her.
Hello.
Hi, Padmaja. So
I'm here. Very much.
regarding anemia and stillbirth, what are your comments? Because we know anemia is the root cause of a large number of problems. Is there, should we blame that even
Of course. Anemia, by knowing the degree of anemia, it throws a light on directly the nutritional status of the mother, the degree of literacy, the vastness of the antenatal care in that particular area, the importance the mother gives to the iron supplements the nurses have given. All this can be known by the hemoglobin status. Many times, though the midwives give and the local people, local nurses give the supplements, they just throw it off and they don't use them because they think that pregnancy is so physiological that they don't need any sort of interventions, any sort of medication. It just goes naturally. But the hemoglobin status throws light on the antenatal care, the importance which the mother has given, and the risk of stillbirth certainly is higher with higher anemia.
So it is almost 4 to 16 times higher odds of stillbirth. And along with anemia, the biggest problem that we face is having PIH. Dr. Baby Shalini, could you throw light on what you call the running in parallel between PIH and stillbirth? And what are we doing to get down the complications from PIH? Okay, I think I did not see Dr. Shalini. Dr. Bahadur, can you take this question, please? In India, regarding PIH, what are our unique features? What are we doing about it? Because all of us, everyone from the beginning, Dr. Satyavati told, Dr. MC Patel sir said PIH and its complications definitely are a nightmare.
Ma'am, yeah, PIH, yeah, definitely it's a nightmare, and it also poses a risk to the mother as well as the fetus. So definitely, PIH is an important factor which we need to address at very in detail. And right from the beginning, when we are seeing the patient in the antenatal clinics, we need to emphasize to the patient and to the relatives that if she is having PIH or she is a potential candidate to develop a PIH, the complications will be much more, not only to the mother, to the baby also. I think if this we keep on telling right from beginning, not to scare them that they may be a stillbirth, in the sense they will be so bad, but we need to sensitize them over a period of time so that if by unfortunately some mishap happens, they understand and then they will take it in a better way.
So your comments on the Gestosis score, Dr. Bahadur?
Yes, ma'am. Actually, if you are practicing in any institution or in a nursing home, if you have a Gestosis score, that will categorize the patient, and treatment to the patient will be much better, and we can give it at an appropriate way. It definitely helps.
Yeah, I for one am a strong I'm an admirer of Dr. Gaurak Mandrukar and the entire team of Foxy, Dr. Suchitra Pandit, Dr. Sanjay Gupte, Dr. Girjawag, all of them had worked so much in getting this. And I think this is also going to be a game changer. Like at every antenatal, have this stuck on your wall, and every antenatal visit, the score systems keep changing. The moment it crosses 3, you know she put her in a high risk category. If at the first visit itself they have a Gestosis score 3, can we do something, Dr. Bahadur?
Madam, can I have it again?
Yeah, if the score crosses 3,
and how to
what are you going to do about it?
Ma'am, yeah, definitely the score is going beyond 3 means there is a potential risk of adverse effects the mother and to the baby also. And as the case, depending upon looking at her BP status, looking at her blood group,
Aspirin.
Yes, start on aspirin. So that was what I was looking for. So as soon as possible. So we will be lucky if we can pick up, because nowadays you see obesity is so high, anemia is so high, primi gravida, PCO, then you have the score more than 4. So you just put her on aspirin as early as possible. Don't wait for any expensive medications. And I think in 60% of the cases, we will be able to do some benefit or the other. I think all the other panelists
Just
were
one
also
second.
listening. So yeah.
This justices score, one advantage is you don't in a low resource setting we can use it. And another thing is this aspirin has been proved that it really helps in preventing many complications and stillbirths. That was a recent data I have obtained from a systematic review following the aspirin trial and all. So I think this is a really good. We can really implement this in our country also.
Yeah,
I think it
so
would make a
it
difference.
is not only important that we think about it, we sensitize our entire staff to do
Yes,
it, because in the trial where they were trying to get down the preeclampsia, they had used 150 milligram, and then they found that there was a lower rate of stillbirth and neonatal deaths also. So when that can also be benefited, I think this is something we should be doing it. And all of us agree that the moment we pick up a high blood pressure, start warning. I mean, they keep telling you us, parvaleda. This is one term I'm terribly scared of, because we tell them. So I always tell them it is the end result that should be good. At 20 weeks, having a blood pressure of 130, 90, we are going to keep you on close monitoring. But we need all of us to say the same thing, that till the end, we cannot assure, we don't know who will go where, because complications in obstetrics can occur like a bolt of lightning. And will you be screening for thrombophilias and clotting factors, Dr. Gayatri? Do you think we should be doing
we don't regularly do the screening profiles unless there is a family history or previous history or any history of clotting disorders, then only we'll be going for that. And history of systemic lupus erythematosus, unless previously the baby has died with some kind of cardiac problem, and where an autopsy has confirmed that there is endomyocardial fibroelastosis, you'll not be screening these regularly. And yeah.
So definitely, if there is a mishap, unfortunately, or as Pavani said previously, bad obstetric history, 10 weeks after a scan, baby was looking okay, and then we had lost the baby. So those are the people in which we should be on high alert. And you can see how wide the spectrum of abnormalities is. And stillbirth after 24 weeks is most strongly associated with protein S deficiencies. So although lupus anticoagulant, tachycardia, antilipids, factor V lead-in, prothrombin levels, all these are also associated with abnormal. And we need to remember that although we are doing rhesus, sometimes rhesus incompatibility gets missed out.
Yes.
So that is also blood group RH is something we definitely need to know. And Pavni, could you see, you were talking about early pregnancy problems, and as you can see, there is a choriodecidual hemorrhage in this girl, and later on the clot disappeared. So what are your comments on this, about its implications for the rest of the pregnancy? Does this sort of picture also increase the stillbirth rate?
Thank you, ma'am. This kind of a picture in the early pregnancy gives us some kind of placental dysfunction. Depending upon how much the dysfunction is, the final growth of the baby is dependent on that. So now talking about fetal growth restriction in terms of how much placenta is involved, fetal growth restriction is directly linked with stillbirths. So this ultimately may land up with growth restriction. The baby may not reach the potential growth which is required and may land up in stillbirth. So in such a condition, as aspirin still works, even though the clot is resolved, the rest of the placenta keeps working, avoiding the mishaps.
So there is a four-fold increased risk of stillbirth whenever there is a choriodecidal hemorrhage. So we need to put them as soon, even if the bleeding resolves, that it is in a high-risk category. And Dr. Uma, we know the maternal health has an impact on the fetal health. So what are the comorbidities about which you will be really alert when you're thinking in terms of preventing stillbirths?
Most important one is gestational diabetes, and all the maternal high risk factors like maternal systemic diseases also we are also worried about, and all high risk pregnancies as a matter of fact, and babies where they're not catching up with the growth, presenting with the growth restriction, there also we have to be very careful, and we have to be on the follow-up of with the Doppler studies and the biophysical profiles and all, so that we can timely deliver them and prevent the stillbirth.
So, and even when
can I say something about safer baby bundle?
Yes, please.
For fetal growth restriction, so monitoring growth is very important. The 5 points in the safer baby bundle: quit smoking. Of course, that is not very relevant with Indians, but of course, rural area do smoke. They do smoke, and growth, checking up on growth, and also movements matter, and the sleeping pattern. Because recently I was looking at that.
We'll
that
come to
sleeping
that.
is also,
I have something on that, Usha.
Yes.
Anything else?
Okay. Yeah. So actually, this is one thing I wanted to tell. Monitoring growth in fetal growth restriction, there was a review where computerized CTG is superior to traditional CTG, and the risk reduction was 0.2. That means 80% have improved. That means, should we start implementing computerized CTG?
It's a thought. If we could do it, it would be great.
Yeah, I think if we could do it.
In those CTGs, are we picking up those prolonged QT intervals that they were discussing?
Yes, actually, the computerized CTG is giving the opinion using artificial intelligence. But of course, it is expensive, and we need to do more capacity building for this.
I know, but if we want to do a QT interval, we will need to do a fetal.
Fetal. No. Fetal.
Cardiotocography.
This is only to monitor growth for fetal growth restriction.
Yes. So even when there are mental health issues, they have a higher risk of stillbirth. This is something we don't need to, we have to be alert, because quite sometimes in families, they're not very okay with telling that she's on antidepressants or something like that. Some of them would not have shared it with their partners. So I always make it a point to tell them to show me all the medicines that they are on. So then we can pick up sometimes. Because having in an OPD sometimes is you miss it out. So previous mental health issues, they're at an increased stillbirth, and this is a double whammy, because having a stillbirth will itself trigger mental health issues. And the burning problem that we have, Dr. Chanu, of PCOS. PCOS is there everywhere. So is it linked to stillbirth also?
Madam, PCOS is such leading to stillbirth. I am not aware of it, but PCOS may have other means like associated health conditions like diabetes. So it itself can increase the risk of stillbirths. So
yeah, and this was something I was looking at. In women with PCOS, they had comparatively a higher risk of stillbirth. What happens is that in these people, the insulin resistance sometimes is not severe enough to cause hyperglycemia. But when they eat a big meal, it causes a reactive hypoglycemia, and that can also cause stillbirth. So dietary advice for PCOS, we should what they were doing previously to lose weight, that eating small, eating frequent, eating low glycemic index food, that holds good even all through pregnancy. Okay. And as we were saying, these reactive hypoglycemias are more common in young, in nulliparous. That is irrespective of the body mass index. So don't think that only an obese PCO is at a increased risk, and that happens because of these refined carb diets. And Dr. Padmaja, I think Padma Shri, Professor V. Seshaya, who has rightly shown us the DIPSI guidelines, can you just run us through this once again? Because I feel we should emphasize it, and this should be the only test we are doing.
Actually, DIPSI guidelines are so simple that any time the patient steps into the OPD, whether she has taken breakfast or lunch or any time, give her a 75 gram sachet of glucose in a glass of water, and 2 hours after check the blood sugar. If it is above 140, she needs to be screened further. So it is the one-step screening test for gestational diabetes, which we are following right now.
Yeah, and why are we so worried about GDM?
Yeah, because India is a diabetic hub, and so is gestational diabetes. All the patients with PCOS are landing up in gestational diabetes, higher BMI, higher insulin resistance, and because of the higher incidence of stillbirth and so the complications, other complications, we are very worried about gestational diabetes.
So abnormal metabolism of glucose has an impact on the placental development. Placentae are big, they're plethoric, and at a microscopic level, there is abnormal angiogenesis and vascularization. And the villi, although they look big, there is a distal villus immaturity. And because of this immaturity, there is hypoxia, increased placental growth factor, which causes again, which is a reflection of the hypoxic environment in utero. And when these unexplained stillbirths, they had a placental microscopy, this distal villus immaturity was there in almost 20%. And in them, it does not have to be always hyperglycemia. At least one or more high blood sugar levels was also recorded. So looking for that, doing a DIPSI is, I feel, a very important. And unfortunately, these babies, these are not growth restricted babies. Sorry, just a minute. The death might be sudden and unexpected, and this comes as a shock in spite of having, as Dr. MC Patel showed us in his first case, it can be on an ultrasound just a polyhydramnios with nothing else there. And yes, please.
Just one suggestion. Actually, we have done a lot of research on hypertension and placenta, but I think we need to do a lot of research and do a lot of dissertations or some research work on placenta and GDM.
Yes, we should. And Dr. Usha, can you comment on about malpositions of the fetus and stillbirths?
Malpositions, and usually what happens is the malpositions that breach or any other thing, the risk of cord prolapse will be there. If it's so definitely it will increase the risk of stillbirth.
And they're more significantly that basically intrapartum death is more common.
Intrapartum, but 40% intrapartum deaths are related to malpositions and malpresentations.
A baby in malpresentation always should be suspected to have an anomaly. The risk of subtle anomalies and sublethal anomalies are higher in
3% more.
Yes.
There are 3% more congenital anomalies compared to cephalic presentations. And one more thing is, when we are talking about stillbirths, there was a idea that we should exclude congenital anomalies from the actual stillbirth definitions.
Yes.
So when I was going to perinatal mortality meetings, they were saying that it's a corrected thing where we are excluding any congenital anomalies. So, in a normal baby, also has an increased risk of stillbirth because of malpositions and malpresentations.
And here, Usha, we are at your sleeping position. You were telling us something about this.
Yeah, actually, there was one study in which they said that we should counsel women regarding sleeping position, and after 28 weeks, we must ask them whenever they're lying in supine position, there was increased stillbirth risk. So that was one factor that we need to stress upon in during our antenatal care.
So it is basically how they fall asleep. It doubles, in full-term pregnancy, if they're sleeping only in that supine position, there's a very good risk. But the thing is, you can't. A woman can't sleep only on one side. 80% of pregnant women at some point of time in their sleep will do lie down on the back. So we should tell them to be a little alert about that.
Or we can ask them, actually, they need a 15 to 30 degree tilt. So we can ask them to put a pillow there to one side and then lie on that. So that it will almost be like, but it will not cause the damage.
So you can see the all sorts of pillows and positions that are possible that we can recommend for women to find a sweet position to sleep in. And as we were saying, when we look at the statistics of where the next 1,000 babies are going to be born, they're going to be born most in India. So it is our responsibility to make sure that those babies are born healthy and those mothers go well. And Dr. Bahadur, sir was telling me that almost 50% of women who had a stillbirth complained of lack of fetal movements preceding it. So what do you suggest about fetal movements in pregnant women? When do you ask them to monitor, and how frequently do you ask them to monitor?
Ma'am, fetal movements, it's subjective. But when at every antenatal visit, we do tell the patient to have a understanding about their fetal movement counts over the period of time, over every day. The best part is that you can tell them after breakfast 1 hour they can observe the number of fetal movements. After lunch they can observe for 1 hour. After dinner they can observe and add up and tell them that at least they should have a 10 fetal movements by adding up these 3 counts, and if they're having 10, it is adequate. But having said 10, I didn't also emphasize that the pattern is more important. Maybe at yesterday they had 10 movements and rest of the movements they were appreciating, but today 10 are there, but the movement quality is not that good. That means that's a sign that they should approach the doctor.
So I think because women almost in 14% had a higher risk of having stillbirth when they had decreased fetal movement. So if a woman says, I don't feel my fetal movements well, something is different, I think it should side as a red alert, although reduction in fetal movements is very common. So there were trials to look at that, the Affirm Mindful Mind Fetalness trial, My Baby Movement trial. They included almost 4 lakh pregnancies, the 40,000 pregnancies, 2.9 lakhs, and the odds ratios were not very great. That means for us to be able to concretely take a step that this, like as Usha was telling, a bundle, telling decreased fetal movements, you have a bundle and something is wrong, deliver. So we are not yet at that level because it is such a frequent occurrence. But we need to put this women into a high monitoring group. And Dr. Uma, if she complains of decreased fetal movements, what are we going to tell her? She came then into the hospital, you heard the fetal heart is good, then she says, now I can feel fetal movements. What are you going to tell her?
Till should be under strict monitoring surveillance, because often they come up with an IUD at a later time. So immediately we have to go with the biophysical profile that will only ensure us the well-being of the fetus. That is the first thing we have to do. And of course, if you don't have that, at least NST has to be there to assure us, and then keep her for a while till she gains her fetal movements again. And it's also sometimes good to have a Doppler also. Sometimes we can see the cord turning around the neck, turning around the feet sometimes, and getting it tightened, isn't it? So even a Doppler also is also important.
So as you have seen, Dr. Satyavati had very nicely shown us Dopplers. Coincidentally, you do a Doppler, you check the AFI, do the NST, do the Doppler, and one of these might give us a hint that something is not right. Because even sometimes when there is a true knot or something, it tightens occasionally, it loosens occasionally. So with movement, if there is a fetal heart rate deceleration, and it is happening frequently, or you see decreased variability, I think it should be on a high alert and we should not dismiss it. And a word regarding infections, Gayatri.
Anytime patient comes with fever or this is basically responsible for that fetal loss, the single pregnancy loss. But not useful when it is in patients with recurrent pregnancy loss. And patients with history of fever, tachycardia, or history of PROM, in those cases, I think it is better to evaluate these infections like toxoplasma, listeria, chlamydial infections would be better.
And
word, just one word.
Yes.
I was just going through placental malaria increases risk of stillbirth nowadays. In the hospital, I've seen every alternate case is Plasmodium malaria. It increases the risk of stillbirth by 2 times. And when I was going through the literature, they said that anti-malarial nets versus no nets, when they were used to prevent this malaria, there was a risk reduction of 0.67.
Yeah. So malaria, basically the malarial parasite thrives on blood. So spleen and placenta are the areas where there is the maximum amount of blood, and that's where the malarial infection happens. It not only causes anemia, it causes a lot of inflammatory cytokines, change in the proteins, lipid peroxidation, and you can see the heat shock proteins that are being expressed in malaria. So this is in the areas where malaria is endemic. So intermittent presumptive treatment during pregnancy in the first and second trimesters has strongly been recommended. And everyone is alert about HIV, but we are forgetting that syphilis is also increasing. So syphilis, villitis, and obliterative arteritis can also cause fetal and newborn mortality. So because in as early as 1940s, penicillin could cure syphilis. So when we have these antibiotics, we cannot say we need a randomized trial. We have to screen for syphilis and rule it out even now. And I think all this we are doing after the woman becomes pregnant. So Pavni, could you talk like shouldn't we start being alert about the outcomes of pregnancy before she becomes pregnant? A preconceptional visit should solve quite a large number of problems. What do you think, and what would you do in that?
Yes, ma'am. As already what we have discussed, like PCOD itself increases the chances of stillbirth and also obesity, all and pre-existing conditions, if not treated well, like pre-existing diabetes, hypertension, if they are not controlled well, uncontrolled diabetes may lead to further congenital deformities leading to stillbirths and also other complications. So preconceptional, even vitamin D deficiencies may lead to placental dysfunctions. So all these can be addressed much before. Sometimes in consanguineous marriages, the family pedigree chart put in a good manner if there are any bad obstetric histories in the family much before the pregnancy happens can help a lot to prevent stillbirths.
And Dr. Chamu, could you just run through these modifiable risk factors that I've put up? So what do you think should be the birth interval? Yeah, please.
So, madam, interval between two deliveries would be minimum of 2 years. So, obesity, if it is there, then we should ask the patient to reduce the weight as the obesity BMI increases, the risks of not only the medical conditions, diabetes, GDM, hypertension, uh, dyslipidemia, stillborn, all these are increased. Yes, tobacco smoking, we have to tell them to quit smoking and other cocaine use. In India and all, it is less, but in Western countries, yes, it is, that is, means like there in their culture. So like advanced maternal age, yes, the maternal age is more, yes, it's increased risks of complications are there. So it's a very high risk pregnancy, and we have to follow up her up means very meticulously. And some means like patients, they may not be following up with proper antenatal care. So we at the first visit itself, we have to tell the importance of doing a proper follow-up, proper minimum of at least 4. And if the patient belongs to a high risk category, high risk pregnancy at the first visit, so we have to give them the proper counseling and the need of adherence to means proper follow-up. We have to counsel them, madam.
Smoking, she need not be an active smoker, but she could also be a passive smoker. So smoking, the husband.
Yes, madam. Yes.
Okay, and I think in the metros we are getting there. So smoking and drug use are going to be something we are going to see even in our lifetime. And so the screening should be not only of the woman, it should be also of the partner, because the male is contributing to half the genetic material. And we need to know about the family nutrition, the lifestyle, the environment that they're in, because if they're living by a highly polluted area, that has. And depression and violence is something we should not forget. We should be able to, if we see something really odd, we should be able to give her the confidence to trust in us. And of course, preconceptionally, rubella vaccine is something we need to do. We need to do a thorough clinical examination, because quite a large number of, I feel the youngsters are not, the common public is thinking that a scan is there, a blood test is there. Why do I need a perspiculum examination? But I think even a perspiculum examination, we should start there. A basic investigation, and if we have a suspicion, take specialized care and involve as many medical specialists as possible. If there is a facility, don't take the entire headache of managing a medical problem on your head. So as we said, the factors that increase stillbirth, these are the predominant things. So either is it maternal, is there an environmental factor, placental abnormality, we will do. And looking at the interventions that really made a difference. Out of 873 Cochrane reviews, they only had qualitative synthesis of 43. And it is very difficult to do a quantitative analysis. And if you look at the colors, the green tick is the one with clear benefit. And the red cross is one with definite harm. The equal, we don't know. Positive green is possible benefit. Orange minus is potential harm. So if you look at all the interventions, I'm just putting this up so not to confuse you, but if you look at all the interventions, most of them we don't really have evidence. The one thing that does have evidence is, as Dr. Usha said, protein energy supplementation in pregnancy. The one that does help a little is insecticide treated nets. And the one thing that could help is even when the midwife led models are well followed, trained attendants take care. And the interventions, if in one community, in one area, we are losing babies, it is important to step up the healthcare in that. And as Uma said, she's seeing a lot of malaria. So that should immediately trigger active management to that. And Gayatri, could you tell a little about ultrasound Doppler, how frequently do you think it should be done? Especially in a case which had a previous mishap? When would you
In a patient with the previous mishap, most often the mishaps may be because of placental dysfunction. So the monitoring of the Doppler is most important from the initial first trimester itself. So in the initial first trimester, do the uterine artery pulsatility index is more helpful to predict whether patient is going to develop preeclampsia later. And even during second trimester, performing uterine artery Doppler would also be helpful in predicting the future, whether the patient is going to develop preeclampsia or any kind of fetal growth restriction. And once after 28 weeks, it is better to monitor the fetal growth. Once you think that the fetal growth is getting compromised, then I think we have to start evaluating the umbilical artery Doppler in a sequential manner, as what Dr. Satyavati madam has already told. So after 28 weeks, if you think it is getting more compromised, you need to do it every 2 weeks to find out whether the Doppler is getting more significantly affected.
So basically, you keep having to judge the risk of prematurity versus an
Hello,
intrauterine
ma'am.
death. And
Ma'am, sorry to interrupt you.
yeah.
I'm Ted Shah from Corona Remedies. We are running out of time.
Yeah,
We have to end this
I
session
just
within 1
wanted
minute.
the two experts to make a comment and then we will close the session.
Okay.
We have Dr. Neelam Agarwal, who's the president of Stillbirth Society. Madam, could you say something?
Yeah, good evening, everyone. I'm sorry I could not attend to the presentation because I was busy in an emergency, but panel has been excellent. Excellent messages have been conveyed and everything you have covered very comprehensively. I would just like to stress on the fact that we must make everybody aware that simple things sometimes will aid in prevention of stillbirth. For example, blood pressure taking. That is very, very important. A simple thing which normally gets missed because people are not, means at the periphery. We are talking of the periphery level, of the community level, right? Quality of antenatal care. So blood pressure must be checked at each and every visit, because high risk patients, when we identify high risk patients, we usually monitor them and prevent the stillbirth. It is only the low risk cases where we do not expect it to be a stillbirth. There we are faced with stillbirths, especially in the community healthcare. So small, simple things taken care of will go a long way in prevention. All factors and those things, everything has been nicely discussed. Then one is cholestasis. So we must ask the patient, especially in the third trimester, objectively we must ask them about the history of itching, because cholestasis is one unrecognized thing which leads to stillbirth in a situation where it is not expected. Rest everything has been covered very well. I congratulate Dr. Patel and his team for having such a wonderful session.
And I will take this opportunity to invite you all to Vijayawada, 31st August, 1st September. We are circulating the brochures. It is the Vijayawada Menopause Society, Vijayawada OB-GYN Society, and the Ages of Indian Menopause Society, which is conducting the South Zone conference. And if Dr. Tamkeen is there, Madam, could you give the concluding comment?
Yeah. Good evening, everybody. I've been there continuously. And
sorry, Madam.
Thank you so much, Dr. Patel, Dr. Asha Jain, Dr. Sujaya, for organizing this, focusing on stillbirths. And everything has been very nicely covered. And the panel was really wonderful, Dr. Padmaja. I enjoyed it very much. And you have covered everything, even the mind fetalness, which is something very new. And a very balanced, evidence-based panel it was. And Dr. Neelam already covered the rest. What I just want to say is that I've put the link to our website and the link to our membership form, 2,500 rupees for the life membership. It's a no-profit organization. Please join us all in this noble cause. And also, I invite all of you at Fernandez Hospital for the annual conference of SBSI on 13th, 14th, and 15th September. We have brought about the Safe Baby Bundle, and I have shared already the PDF, or you can go to the website also. It will be available, and also the consensus statement of SBSI on evaluation after a stillbirth. And I hope everybody will find it very useful. So please join us all once more, and thank you very much.
Yeah, thank you.
So big round of applause for Dr. Padmaja Madam, nicely conducting panel, and all the panelists who have made this panel very interesting. And special thanks to Neelam Madam and Tamkin Khan Madam. They have joined this panel on my personal request. So thank you. Neelam Madam was held up in some emergency, but still she has joined. So thank you, Madam, for the same.
Thank you, Dr. Patel, for giving us the opportunity and giving us this honor. Thank you so much.
Thank
you, sir. Good night.
Thank you, sir. Thank you, sir.
Thank you, sir.
All respected guests of honor, our chairpersons, panelists, moderator, and speakers for being here. Due to shortage of time, I cannot take everyone's name. I have a thread that the program is going to finish at 8:30. Thank you, MC Patel, sir, for allowing us to be here. And I request everyone on sir's behalf and my own to please nominate us and then subsequently vote for us. Sir for President Foxy and me for Chairperson Food, Drug and Medico-Surgical Equipment Committee. Thank you so much. Thank you for being here. Thank you, Corona Remedies and Teerth Shah, for being our academic partners. We have not delayed you by more than 7 minutes. All delegates and viewers who have made this whole program worthwhile. Thank you. Thank you, Padmaja ma'am.
Thank you, madam. And all the best to both of you, madam.
Thank you. Thank you.
Thank you, madam. All the best to MC Patel and team, and Asha Jain, madam.
Thank
all
you.
the best, madam.
Thank you, ma'am. All the best to you.
Thank you. Teerth, you may end it.
Oh, yes.
Okay.
Okay. Namaskar.
With your permission, I will take this session.
Oh, yes, you can conclude.